Delivery of Therapy to Brain Tumors by James K.C. Liu, Andrew T. Healy, and Michael A. Vogelbaum. Malignant gliomas are the most common type of primary brain tumors in adults. Approximately 20,000 new cases are diagnosed each year. The success of targeted chemotherapy, although considered to be a promising strategy, is impaired by the presence of the blood-brain barrier and partially functional blood-tumor barrier. Current strategies are aimed at designing new approaches that will improve drug delivery to brain tumor cells through various physiological barriers with limited systemic toxicity. Physiological barriers to delivery. The primary barrier to drug delivery is the blood-brain barrier. It is composed of a layer of endothelial cells that line the blood vasculature throughout the brain, held together by tight junctions, and is supported by astrocytes. It prevents crossing of large water-soluble molecules. It also allows passive diffusion of small lipophilic molecules. Molecular permeability is determined by each agent's octanol water partition coefficient and the unidirectional transfer coefficient. The octanol water partition coefficient is a measure of the solute's lipophilicity. The unidirectional transfer coefficient is the ability of a drug to pass from the plasma into the brain. It is determined largely by lipid solubility because agents must first dissolve in the lipid membranes of the blood-brain barrier to cross by lipid-mediated diffusion. The unidirectional transfer coefficient can be plotted against the partition coefficient. This figure demonstrates the relationship between blood-brain barrier permeability and octanol water partition coefficient of chemotherapeutic agents. The solid line is the least squares fit to the data for agents that are not actively taken up by the brain or pumped out by the blood-brain barrier. In this plot, many of the chemotherapeutic agents fall below the line predicted for blood-brain barrier passive diffusion. There are different types of transport across the blood-brain barrier. Active or facilitated transport is used for substances with low partition coefficients. Glucose amino acids and small intermediate metabolites are transported via facilitated transport. Larger molecules, such as insulin and transferrin, are carried across the endothelial layer via receptor-mediated endocytosis. Most chemotherapeutic agents are bound to plasma proteins, reducing the free fraction of the drug in the plasma that is available to cross the blood-brain barrier. The molecular weights of these agents often exceed 400 Daltons, preventing passive transport. Expression of high levels of drug efflux pumps, such as P-glycoprotein, also remove chemotherapeutic agents. Organic anion transporters and glutathione-dependent multi-drug resistance associated proteins also contribute to the efflux of organic anions from the brain and CSF. Another barrier to drug delivery is the blood-tumor barrier. This is formed due to abnormal tumor vasculature compromising the endothelial tight junctions. Drug delivery is inconsistent due to distended capillaries with leaky walls and sluggish flow. Leaky tumor vasculature may result in higher drug clearance that extends radially into normal brain. Studies have demonstrated targeting vascular endothelial growth factor, such as using bevacizumab, may decrease interstitial pressure and greater drug entry into the tumor. Another barrier is the blood-cerebral spinal fluid barrier. This is composed of specialized tight junctions of epithelial cells in the choroid plexus. Tight junctions are between the epithelial cells of the choroid plexus rather than at the endothelial layer. This does not contribute significantly to drug entry into the brain parenchyma due to the relatively small surface area compared to the blood-brain barrier. Drug modifications for enhanced delivery to brain tumors. Multiple drug modification techniques have been developed to improve drug delivery into the brain. One of the techniques is using lipophilic analogs. These are formulations of chemotherapy drugs that allows for passive uptake into the brain. The efficiency of these analogs may be affected by drug receptor interactions, increased binding to plasma proteins, as well as decreased solubility into the brain interstitial fluid. The advantage of this technique is that it allows for passage of large polar molecules. Disadvantage is that there is limited activity against tumor cells due to limited solubility, such as seen using the drug carmustine. Prodrugs are another modification technique. These include modification of the drugs that require a chemical or biochemical transformation to achieve an active form. These drugs are designed to overcome pharmaceutical and pharmacokinetic limitations of the parent molecule. Studies have demonstrated improved delivery of these drugs, but have failed to see an increased drug activity. The advantage of this technique is an improved penetration compared to the parent drug. Disadvantage include the need for a chemical transformation to activate the drug. Another drug modification technique involves the use of antibody and gene-directed enzyme prodrug therapies. These allow for enhanced prodrug activity at the site of action with minimal systemic toxicity. In antibody-directed enzyme prodrug therapy, enzymes that activate prodrugs are first conjugated to tumor-selective monoclonal antibodies and delivered to the tumor via intravenous infusion. When the conjugate is cleared from the blood, a prodrug is then delivered and activated by the tumor-associated enzyme. In gene-directed enzyme prodrug therapy, the inactive prodrug is first delivered, then activated by an enzyme which is delivered to the tumor for expression. An example of this strategy is the use of thymidine kinase gene delivered via a herpes simplex virus to activate the prodrug ganciclovir. In a phase 2 study using thymidine kinase to activate valacyclovir in high-grade gliomas has demonstrated survival benefit. The advantage of this strategy is the enhanced drug activity as well as more specific targeting. Disadvantages include antigen and antibody counteractions as well as inefficient gene delivery to the tumor cells. Receptor and vector-mediated drug targeting have also been used to improve drug delivery. Utilization of endogenous transport systems for carrier-mediated drug delivery has improved CNS delivery significantly. Transport systems include those for glucose, amino acids, choline, vitamins, low-density lipoproteins, and nucleosides. Glucose and the large neutral amino acids are the most used due to their high transport capacity. In addition, transport through olfactory and respiratory epithelium have demonstrated promising results in early phase 1 and phase 2 clinical trials. Intranasal delivery allows drugs to rapidly reach the CNS tissue, avoiding hepatic drug metabolism and reducing systemic side effects. The advantages of these techniques include utilization of existing transport systems and vectors to improve uptake. Disadvantages include immune-mediated responses upon injection. Barrier disruption techniques. One of the techniques for barrier disruption is osmotic disruption of the blood-brain barrier. This is achieved through localized vascular distribution of intraarterial infusion of a hypertonic agent, such as mannitol. Following injection, fluid diffuses rapidly out of the cells, causing shrinkage of endothelial cells with opening of the tight junctions of the blood-brain barrier for several hours. Animal studies have demonstrated a 90-fold increase in drug concentration. Methotrexate delivery was enhanced 4 to 7-fold with osmotic disruption. Concern for risk of neurotoxicity due to high drug concentrations exist. An alternative strategy is biochemical disruption. Mediators of inflammatory responses such as leukotrienes, histamines, and vasoactive peptides can cause transient permeability of blood vessels. Bradykinin, a peripheral vasodilator, increases the tight junction permeability by activating bradykinin B2 receptors of the endothelial cells. This is less invasive and allows for more precise time window compared to osmotic disruption. Clinical trial of RMP7, a bradykinin agonist, and carboplatin was discontinued due to high level of toxicity. Another strategy for barrier disruption is the use of ultrasound-mediated disruption of the blood-brain barrier. Blood-brain barrier disruption, with a large volume as produced with osmotic and biochemical disruption, may prove to be a disadvantage for many applications because the agents may have undesired side effects as a result of their spread within the CNS. Ultrasound-mediated disruption allows for localized and reversible image-guided disruption of the blood-brain barrier. This is performed by delivering preformed microbubbles intravenously into the tumor. This is followed by MRI-guided focused ultrasonography that is applied and causes cavitation-generated mechanical stresses to the blood vessel walls secondary to the presence of the microbubbles. The results are a consistent vascular leak without tissue damage. The opening of the blood-brain barrier is reversed within 24 hours. This has been demonstrated to enhance delivery of temozolomide and irinotecan in rabbit models. One of the challenges in translating preclinical studies into humans is the variable thickness of the skull. This was circumvented through the use of the SonoCloud, which is an implantable ultrasound transducer that can be activated following implantation through a transdermal needle that can induce blood-brain barrier disruption. Hypothermia can also be used to induce blood-brain barrier disruption. Heating of the head to 42 degrees Celsius for 30 minutes has demonstrated increased delivery of adriamycin-encapsulated thermosensitive liposomes in glioma mice models. Similar results have been achieved through infusion of warm saline or laser-induced thermotherapy. The use of focused thermal therapy in inducing coagulation and destruction of primary and metastatic brain tumors has progressed significantly through the application of MRI-guided laser interstitial thermal therapy. Although the progress of lead therapy has been primarily focused on tumor ablation, it has been shown that thermal therapy can disrupt the blood-brain barrier 1 to 2 weeks after ablation and lasts up to 4 to 6 weeks. Strategies for direct delivery to the brain. Conventional methods for the treatment of brain tumors usually involves delivery of drugs via the systemic circulation. Systemic drug levels must often be high to achieve adequate drug concentrations at the site of the brain tumor, which usually necessitates increasing the dose, frequency, or duration of drug administration, with consequent systemic toxicity. This can be circumvented through direct interstitial delivery, which allows the circumvention of the systemic circulation and the blood-brain barrier. The main advantage of this technique is the reduction of systemic toxicity. Among the challenges to interstitial delivery include the presence of diffusion gradients, infusion rates, tumor cellular architecture, and the interstitial architecture, as well as physical limitations to the delivery device. Radially oriented pressure gradients that favor drug distribution from the center to the periphery of a tumor are also obstacles that must be overcome. A method of direct delivery is the use of implanted polymers. These are drug-impregnated wafers that allow for drug delivery with a controlled sustained release rate. The first FDA-approved polymer was Gliadel, a carmustine-loaded biodegradable polymer wafer developed by Bram and colleagues. The drug was released by a combination of diffusion and hydrolytic polymer degradation. The initial trial demonstrated an increase in mean survival time for patients with recurrent gliomas. This was eventually approved for newly diagnosed or recurrent glioma in patients who are undergoing a gross total tumor resection. Drawbacks of this technique include the high initial concentrations that are necessary to overcome the rapid concentration reduction that occurs only millimeters beyond the resection cavity. High drug concentration at the surface of the polymer increases the risk of local neurotoxicity and poor wound healing. These steep concentration gradients remain a major limitation of diffusion-driven delivery approaches. Another strategy of direct delivery is the use of intracavitary delivery systems. These are intraventricular or intracavitary systems which allow for drug delivery through an access port underneath the scalp. These allow for delivery of intermittent bolus injections of anti-cancer drugs directly to the tumor cyst or cavity. These are primarily limited by infections, catheter obstructions, and inadequate drug distribution. Convection-enhanced delivery is another strategy of direct delivery that was initially developed by Bobo and colleagues in 1994. This involves the continuous infusion of a therapeutic drug under positive pressure. The bulk flow mechanism is created by a small pressure gradient from a pump that pushes solute through a catheter targeted within the CNS. Advantages include bypassing of the blood-brain barrier. It also provides targeted delivery of the drug. The pressure-driven delivery enhances distribution compared to diffusion-limited delivery. Also, it provides for localized distribution with limited neurotoxicity. The technique of convection-enhanced delivery involves the placement of one or more catheters stereotactically. Pressure-driven drug flow is delivered via an infusion pump. The agent is directly infused into the target tissue at a predetermined concentration rate and duration. Infusion rates are adjusted to achieve optimal distribution volume, which will vary based on tumor cytoarchitecture. Several preclinical studies have demonstrated effectiveness. Hadesic and colleagues effectively delivered AAV2 thymidine kinase and AAV2 aromatic L-amino acid decarboxylase to monkey brains. Phase 1 and 2 clinical studies examined intratumoral CED of paclitaxel in patients harboring recurrent glioblastomas. They achieved a response rate of 73%. The study was also associated with a significant incidence of treatment-associated complications. Another study of chronic topotecan infusion into rat glioma models demonstrated a greater than 5-fold increase in survival times without significant neurotoxicity. Although a promising strategy for treating malignant gliomas, initial convection-enhanced delivery trials failed to show survival benefit. Among the main limitations was the catheter design. Previous catheters were disadvantaged for several reasons. They allowed for backflow and infusate with increased infusion rates. They were limited to intraoperative usage, and they were limited on the volume and direction of the drug distribution. The Cleveland multiport ventricular catheter was designed to circumvent these previous catheter failures. The CMVC is a quad-lumen catheter designed for high-volume drug delivery into the brain. In a first-in-human trial, the CMVC was demonstrated to provide backflow-resistant drug delivery into brain tumors and tumor-infiltrated brain parenchyma. Topotecan and gadolinium was delivered via stereotactically implanted catheters to recurrent GBM over a period of 96 hours. Co-infusion of gadolinium allowed for evaluation of delivery and assessment of the volume of distribution. This study demonstrated the value of an MRI-compatible catheter that was capable of high-volume delivery. It also allowed an analysis of the volume distribution within enhancing and non-enhancing tumor, demonstrating that the maximum volume of distribution for enhancing tissue was significantly greater than in non-enhancing tissue. Alternative drug strategies. Alternative delivery strategies include intraventricular and intrathecal drug delivery. Utilizing the CSF space for delivery of chemotherapeutic agents has been a valuable method of treatment for some patients with CNS malignancies, particularly in the leptomeningeal space. Although effective for leptomeningeal disease, paucity of bulk flow between intracellular space of the brain and CSF leads to poor parenchymal distribution. Intra-arterial therapy allows for delivery of higher concentrations of drug via the arterial route, which increases the amount that crosses the blood-brain barrier. Intra-arterial administration of etoposide resulted in 4 times higher concentration than IV administration. Several studies have demonstrated increase in brain parenchymal concentrations. None of the studies, however, have shown improved survival with intra-arterial versus intravenous delivery. This strategy is limited by the high degree of drug toxicity and the lack of treatment to the contralateral hemisphere. This strategy may be effective when combined with blood-brain barrier disruption techniques. Liposomal drug encapsulation can also improve drug delivery. The use of liposomes for targeted drug delivery have shown their efficacy and tolerability, as well as their ability to carry imaging markers in tumor-selected moieties, such as immunoliposomes. Systemically administered liposomes are selectively removed from the circulation by phagocytic cells of the reticuloendothelial system, making them effective for tumors of the liver and spleen. Favorable distribution properties allow for reduction of unwanted drug tissue interactions and decreased drug clearance rates from target brain parenchyma. Immunoliposomes can be pegylated to facilitate successful brain delivery. Clinical investigation is focused on optimizing the delivery of these agents both via the systemic circulation and by CED. Nanoparticulate systems demonstrate greater stability and drug delivery capacity compared to liposomes. These are made of natural or artificial polymers ranging in size between 10 and 1,000 nanometers and can be injected intravenously. Surface modification can be performed to express ligands to facilitate blood-brain barrier passage as well as tumor selectivity. Magnetic microspheres can be created by encapsulating anti-cancer agents within a polymeric matrix. Through the application of an external magnetic field, the tumors are forced to retain cationic particles. This allows for enhanced ability to localize delivery at the tumor site while limiting systemic drug distribution. When administered via convection-enhanced delivery, magnetic microspheres offer the ability to monitor drug distribution and also may reduce tissue clearance rates. Bioadhesive cationic microspheres have been shown to increase particle retention at the brain tumor barrier. Small, uncharged magnetic particles have demonstrated increased targeting of intracerebral grade 2 glioma in rat models. Conclusions. The blood-brain barrier creates a significant obstacle in preventing the effective delivery of chemotherapeutics to brain tumors due to a combination of tight junctions and neighboring astrocytes. Active transport also plays a factor in preventing effective drug distribution through the blood-brain barrier through the expression of high levels of drug efflux pumps. Modification of drugs into lipophilic analogs or in conjunction with lipophilic carriers, can potentiate passive diffusion through the blood-brain barrier, but high tissue clearance rates can result in limited distribution. Delivery into the brain parenchyma can also be achieved through disruption of the blood-brain barrier, which can be accomplished through numerous methods, including MRI-guided ultrasonography and thermal therapy. Convection-enhanced delivery through direct intraparenchymal injection is a promising technique but has been hindered by limitations in the design of the delivery catheters. The Cleveland multiport ventricular catheter has demonstrated effective delivery of chemotherapeutics into the brain parenchyma while reducing backflow.